and I think part of that is because actually the terminology is confusing. I mean, heart failure implies that the heart as a pump is failing, which it is in heart failure, but actually the clinical syndrome of heart failure refers to what happens after that and the way that the body responds to reduced heart function. It responds in a way that leads to retention of water and sodium and an increase in blood volume, and that's what causes all of the symptoms and signs in heart failure that mainly relate to fluid congestion. And it's, I think one way to think about why does the heart respond in this way is to go back and think about maybe how these neuroendocrine systems evolve, or the context in which they evolved. So these are paintings from the, I don't know how you say it, Chauvet cave, which are about 36,000 years old, showing lions in France, in the middle of France. And I guess at this time, heart failure was probably quite a rare condition. It's, you know, an age-associated disorder that's driven by high blood pressure, obesity, to some extent infection. But at this time, you know, going back to, you know, to the context in which humans evolved, there were other threats to life, like mainly injury and bleeding, and actually it's the response to low blood volume that that we have to bleeding and blood loss or infection that gets activated when we have reduced heart function. And actually that's a kind of misfiring of a system. It's not helping those patients. And ultimately all our treatments actually counteract that that response to a failing heart. And this is summarized really brilliantly by Peter Harris. I think this paper on evolution in the cardiac patient is probably the clearest description of heart failure that I've ever read. And it's written in 1983, before any of the randomized trials had come out for the drugs that kind of prove his point. And he summarizes at the end of his, you know, this kind of this opinion piece that when the output of the heart, when the output of diseased heart decreases, the body reacts in a way for which nature has programmed it. It cannot distinguish, i.e., what the cause of sensed hypovolemia is. But now the neuroendocrine response persists over weeks, months, and years, and the retention of saline threatens the cardiac patient with drowning in his own juice. And every hour of the day and night, he is running for his life. And I mean, this also, you know, highlights the fact that some of this physiology is also the physiology of exercise, where water and sodium are retained when you're running a marathon. But these patients with heart failure are effectively in this physiological state all the time, and that's actually what leads to a lot of the progression of heart failure after the initial insult to the heart. So it's, you know, I'm going to talk a bit, I'll just give some highlights really in this talk of how we've tried to understand those mechanisms, disentangle the complex mess of interacting risk factors that are often present in these patients, try and bring clarity over some questions about what the causes of heart failure are, and just some of the things that we've sort of found through the GWAS efforts and some of the MR. So I'll go through. I may need to skip over a couple of these for time. I think people are aware of the challenge. Heart failure is one of the most common causes for unplanned admission to the hospital, and its prevalence is increasing with the demographic shift of the population to an older population. And I think, you know, most people, if you live long enough, you'll probably develop heart failure. So really, what we're interested in is patients who develop this condition earlier on. And we've made great strides forward in treating these patients, but there still remains a significant burden of disease. I've talked, so that the current definition is that it's symptoms and signs caused by structural or functional abnormality corroborated by elevated natriuretic peptides, i.e. evidence of fluid overload. But it's an awkward definition, and I think and you can see that this year alone, 2 separate articles have been published proposing different universal definitions for the disorder, so it still hasn't sort of settled. And I think part of what I'd like to propose, I think when we try and understand this disease, we need to sort of disaggregate the components of it and maybe some of the progression GWAS that I'll just very briefly touch on today, literally one slide, may help us to hopefully to do that, to tease apart the different components of the disease. So just to summarize again, you have a variety of cardiovascular disorders which can lead to a reduction in the pumping function of the heart, a failure of the heart to function. And the way that the body is primed to respond to that, probably evolved as an injury response or a response to bleeding, is to then signal to the kidneys to retain fluid. So we call it heart failure, but really it's a disease which couldn't happen without the kidney. And in some ways, it's very difficult to distinguish from kidney failure. So we actually call heart failure this syndrome which results from the way that the kidneys are driven to respond to reduce pump function. This is heart failure, the fluid retention. And the reduction in pump function is actually, we call it left ventricular dysfunction or cardiomyopathy. So this is some of the confusion about what heart failure actually is. And I think we need to study these entities separately to make progress. One thing that's notable about cardiovascular diseases as a group is they all have quite a benign, on the whole, outlook until you develop heart failure. So if you can prevent heart failure, these cardiovascular disorders actually have a relatively good prognosis, with some notable exceptions. But I think by and large, the prevention of heart failure is really a lot of what we in kind of clinical cardiology are focused on achieving. So understanding how cardiovascular diseases lead to heart failure is obviously important. This is what I've said. Most patients with cardiovascular disease develop heart failure. Those who have it tend to die from it. And the other problem that we have is that we very often see, and I think increasingly, patients arriving with their first presentation of cardiovascular disease with advanced heart failure in A&E in the hospital. So I think ultimately trying to find a way to identify those patients earlier is also an important public health objective. So this is the busy slide. This is just summarizing the point that all our therapies, so we've made huge steps forward to improve the mortality outcomes in patients with particularly reduced ejection fraction heart failure. But all the treatments that we have actually target this renin-angiotensin system. And this is the system that's activated when you have a hemorrhage. And it's the system which is activated when you have a failing pump. And it's the system that leads to a sort of positive negative feed forward loop that causes further strain on the heart. So all our treatments are counterbalancing a natural defense mechanism that was perhaps evolved for different purposes. And we've seen huge benefits, as I said. So this is a network. These are results of a network meta-analysis here, the hazard ratio for mortality, and looking at different combinations of sort of contemporary medical therapy for reduced ejection fraction heart failure. And you can see the estimates for mortality reduction are quite striking. And I think really it's fair to say this represents a real triumph of modern medicine. We actually have new medicine to add on to this, the SGLT2 inhibitors, which actually lead to further reduction in mortality. So it's become very enjoyable to practice heart failure medicines because patients really feel better when you see them. And you really, we have on solid ground knowing that we're making them live longer, at least for those with reduced ejection fraction, because it's a different story for half the patients who don't have reduced ejection fraction. So just to explain that a bit more, so that when the heart fails as a pump, it can broadly fail in two different ways. One, the common form is what I've been talking about, this reduced ejection fraction heart failure, where the muscle becomes weak in its contractility and as a consequence dilates, becomes big. And that's the form where we've got good treatments and we've made good progress. But about a half of the patients, and a proportion that's increasing with aging of the population, their heart function looks relatively normal, or they may have some hypertrophy, thickening of the heart muscle. But they do have elevated pressures in the heart, but they don't have the same phenotype of failure. And we've done actually a couple of Cochrane reviews looking at all the renin-angiotensin therapies for this group of patients. And this is a summary of some of the results, just showing that those medicines which improve mortality so strikingly and reduced ejection fraction heart failure seem to have probably have no effect on mortality in patients who have preserved squeezing function of the heart. I mean, this beta blocker result actually falls away when you remove the studies with a huge risk of bias. So some of the key questions, I think one is about what is this diagnosis of preserved ejection fraction heart failure that looks so similar to kidney disease? They've got heart failure with hearts that don't seem to be failing. And I think that's that's a huge topic, an area of interest. There's still question marks over what the risk factors are for heart failure and where we should be focusing our attention in terms of prevention. What are the determinants of adverse outcome? Why do some patients do much worse than others once they have prevalent disease? And also, is there anything that we can do about it? Are there treatments that we can identify? I think there is a question of whether there's an alternative path to the fluid congestion, this activation of RAS, which is different, and whether there may be an unrecognized disease entity that relates to that specifically. So to answer some of these questions, I put this is Bristol Zoo. I've basically put together with Dan Swerdlow, we were actually in Bristol Zoo when we came up with this plan to set up this consortium to do heart failure genetics. We were at one of the MR conferences here. I mean, it was an idea we'd had before, but it was really sort of, I think we had to sort of fix on the plan.
Tragically, it's been shot.
I know.
200
yeah. That is, yeah, real shame. Anyway, so but at the time, we were interested in trying to tackle some of these questions, but there just wasn't there wasn't a GWAS resource that would enable us to do it. So we started to try and create one, and then it really just snowballed in terms of the interest. I think it was a latent interest. This was, I think, in about 2016. So we've established this consortium, and we've now made this is a summary of the GWAS landscape. There wasn't much before 2020 really in terms of large studies, and then there's been a bit of an explosion since then. This was our first study here, first large study, and then these are, so I'm going to talk a bit about these two studies and just a couple of things that we've learned so far. This is sort of being worked up for publication. We've also, I'm not really going to talk about it, but we've also begun to do large-scale GWAS studies of the seemingly inherited autosomal dominant cardiomyopathies, which may actually be more complex than we had, or they had been thought to be. So our first study here was really just trying to take a broad group of patients with heart failure, to get enough numbers and not to try and refine the phenotype. And then what we did then is we were very pleased at that time to have 11 loci, and but it seems like a small step to have made, but it was the first step. And then we basically tried to disaggregate the phenotype after, sort of through downstream analysis. And we looked at how these risk loci for heart failure were related to upstream risk factor traits, and then actually clustered the loci using agglomerative clustering based on their associations with upstream risk factors. And as expected, we see a clutch of loci which are related to coronary artery disease, elevated BMI. But interestingly down here, BAG3 and CDKN1A, which are loci which don't have many cross-trait associations, that actually turn out to be loci associated with reduced contractile function of the heart and dilated cardiomyopathy. And particularly of interest is this CDKN1A, which this is just this is actually our recent work where we're trying to automate gene prioritization and then sort of aggregate results across different methods, including POPs, TWAS, and the open targets variant to gene. And CDKN1A really comes out as a striking sort of candidate. And interestingly, I think it has a very plausible story. So this is a study I won't go into, but essentially after about 2 or 3 weeks after birth, your cardiomyocytes stop dividing, and mostly they stop dividing for the rest of your life, and you basically deplete over your life course. There is a low level of renewal, maybe in the single percents over that time, and it's been a source of endless experimentation, including I spent 3 years of my life trying to show that stem cells were the source of new cardiomyocytes, which turned out not to be the case. And actually, as this sort of pivotal experiment shows, by labeling cells with that basically you do get new cardiomyocytes are developed during adult life, but they come from the division of existing cells. And CDKN1A turns out to be a master regulator of cardiomyocyte cell cycle division. So this is, plausibly patients who have this sort of lower rate of renewal, dialed back rate of renewal, may be more susceptible to late onset diseases, perhaps because of a lack of resilience in the face of other risk factors. So we're actually, pursuing this further, and through animal work now, in collaboration with Ravi Kara and Duke. So anyway, that got us started, but then really we always knew we needed to do more to sort of tease out the unique phenotype of heart failure. So that's really been our focus recently in this Hermes 2 analysis. And here we took all the we did a lot of work in developing EHR phenotypes to try and clean up the cases and to aggregate data from different types of studies. So we have clinical trials, population studies, lots of the large EHR biobanks. And we created a sort of multimodal phenotype definition that could, pick out cases using the best available phenotype data from within the studies. And what we did is we took all heart failure, and then we excluded from, so these yellow bubbles are the GWAS phenotypes. So then we excluded all patients who'd had a myocardial infarction or revascularization for coronary disease, or had surgery for valve disease, or had congenital heart disease, and then left with what we then call primary heart failure that seems to occur without a very large risk factor that's identifiable. And then from that population of primary heart failure, where the heart muscles seem to be the main sort of main issue, we then divided that population into using quite stringent phenotyping for the time of measurement of left ventricular ejection fraction into those who had this typical form of heart failure, the reduced ejection fraction, for which we have good therapies, and also this HFpEF phenotype where the function is seemingly preserved. And this is a summary of the studies that contributed. We tried to go cross ancestry, so we've it's still a disappointingly small amount of non-European ancestry in our sample, but we did our best, and I think it does represent a step forward. And you can see here from the QQ plot, our original study in 2020, we've obviously we've now got about 150,000 cases in our main heart failure, dropping away with the subtypes, but we see a substantial boost in our GWAS discovery. So I'm not going to present details about this. We're sort of preparing this manuscript for, but just some snippets really. So that what we see, this is the H2 SNP, so there's heritability due to common genetic variation, which is estimated using LDAC, the SUMHER model. And what we see is that the heritability of heart failure is very much within the subgroup of patients who have reduced ejection fraction, but we do have appreciable heritability in the other subtypes. But I think what's emerging is that there's a sort of, as I'll go on to later, there's a reduced contractility phenotype that seems to be a major driver of disease in heart failure, and that has this important genetic component that's probably overlaps with other forms of cardiomyopathy. And then there's this primary sort of HFpEF phenotype is a much more sort of multimorbid and complex etiology that's less genetically driven. So some of the insights from risk factors, so here are just a couple of examples. So here using those data here's the code. So the all heart failure is in pink, and then the primary heart failure, so here, and then stratified by ejection fraction here in green and blue. So what we've done here is throw out essentially all patients who've had a myocardial infarction. So that myocardial infarction included in the red, and it's not included in any of these three primary heart failure phenotypes. And it's a classic sort of correlation causation thing where we see here that, there's a high level of genetic correlation of shared genetic factors that influence variance in liability to these two disorders. And there's actually there appears to be a causal relationship as expected between coronary artery disease and heart failure risk. But when we remove all the patients with myocardial infarction essentially from that group, we see that signal goes away completely, and from all the groups, although you still have some shared genetic etiology, which presumably relates to shared risk factors for the two conditions. And this crudely, we've got this kind of situation where stable coronary disease doesn't seem to be a cause for primary heart failure, i.e. heart failure in the absence of myocardial infarction. Although this may seem sort of obvious, it's been an enormous source of 3 decades of research around, does ischemia cause left ventricular dysfunction and heart failure? And people have undergone bypass operations and stenting and treatment of stable coronary artery disease with one aim of which to prevent heart failure. And it really looks like that. And this hypothesis of that an underperfused myocardium is hibernating and can be recovered by opening up narrowings in epicardial vessels seems to be wrong. And actually, the results of the ischemia trial, which was a trial of patients with stable coronary artery disease, and trying to see whether you could prevent MACE events by revascularizing those patients with ischemia, it showed actually that the hospitalization for heart failure was greater in the intervention group than in the control, if anything, although obviously not reaching any level of, well, actually did reach a level of significance, and no effect on all-cause mortality. So I think this is where the genetics is really helping to sort of to add something to what we know in the clinic. And it's difficult because you see the patients in the clinic, you have horrible coronary disease. Oh, should we be doing something about this? But I think it's clear that we shouldn't. Another one that's really key, I think, is adiposity. And if lions were the threat in 36,000 years ago, then the threat now, I think, is this processed food. And it seems that excess adiposity seems to be probably one of the most important risk factors for all forms of heart failure. So the genetic correlation is quite high, and so are the causal effects. And if anything, in the HFpEF group, if anything, the point estimate is higher. We actually, we know from observational studies that obesity and overweight is an important risk factor for heart failure. And then it begs the question: what's the root? How does that excess adiposity lead to heart failure? And these are actually using our old GWAS data set, and this manuscript, which we're currently updating, is it's on medRxiv. We did a sort of multivariable Mendelian randomization to try and identify what the mediators, or to approximate what the mediators of BMI heart failure relationship is. And we found that whilst there is a sort of some effect that seems to go through these common risk factors, there's a lot of unexplained. There's a lot that's unexplained in terms of the relationship of BMI and heart failure. And actually, I haven't got slides here, but actually it's interesting that BMI is also something that seems to, it's increasing the load on the heart by making the demanding of the heart a greater cardiac output. And that also is a physiologic adaptation to the need for greater cardiac output that seems to become deleterious and lead to heart failure, somewhat analogous to the situation with hemorrhage and sense hypovolemia. So another one, I think the last sort of story from this is around maybe the relationship of contractility to different forms of heart failure, and the relationship of the rare, seemingly Mendelian cardiomyopathies and sort of garden varieties of HFpEF and HFrEF. So we used a tool. So somebody I know somebody at Bristol developed Mendelvar. I should have a reference on here, but this is basically looking to see whether the sets of genes which are known to lead to Mendelian forms of Mendelian disorders, whether those gene sets are enriched within the loci, in this case for the heart failure GWAS. And so we see, kind of unsurprisingly, that the most greatly enriched Mendelian disorders, the greatest overlap, if you like, is for the cardiomyopathies. And so we sort of, begun to think about what's the relationship between genetic risk of cardiomyopathy and these heart failure outcomes. And so this is again the same frame of genetic correlation and Mendelian randomization. We see, as you would expect, that left ventricular ejection fraction, which is a measure of how good the contractile performance of the heart is. When you've got that big and baggy and weak heart, you've got reduced ejection fraction so it captures contractility. And we see that genetically predisposition to lower ejection fraction is a very strong risk factor for reduced ejection fraction heart failure, as you would expect. And if anything, for the preserved ejection fraction heart failure, it's the opposite is the case, and that if you're predisposed to have a higher ejection fraction, you're at greater risk of HFpEF. And we also see that genetic liability to hypertrophic cardiomyopathy. So this is from a GWAS of patients with a seemingly Mendelian disorder, or if you like, a phenotypic extreme of cardiac hypertrophy. That if you do a GWAS for them, and then here we're developing instruments of genetic liability to hypertrophic cardiomyopathy, you see that is, I think it just scrapes significance as a risk factor for HFpEF. So and hypertrophic cardiomyopathy is a disorder which is characterized by supranormal function and hypercontractility of the heart muscle. And in fact, drugs have just been approved. The first drugs, disease-modifying drugs in hypertrophic cardiomyopathy, which actually inhibit the myosin ATPase which is the kind of the engine of contractility in the heart, and they actually inhibit it. So they reduce the force of cardiac contraction and seem to improve at least surrogate outcomes. And I think we're pretty sure that they will result in a mortality benefit when those trials are completed. So there seems to be something between hypercontractility and HFpEF, some relationship between these disorders. This was work led by Connie Betzina, where we showed that if you look at the GWAS of hypertrophic and dilated cardiomyopathy, these two disorders which are at the extreme of a continuum of contractility, you see that they're sort of genetically opposite. So if you perform genetic correlation for these two different phenotypes, you see that you have these opposing effects, which in a way mirror what we saw on the previous slide. And the GWAS hits for HCM are risk loci for DCM and vice versa. So I think it's quite in some ways an obvious, but quite a useful finding. I think it's helping us to understand HFpEF better. And just a final comment on HFpEF, this is the relationship between blood pressure that we've estimated genetically. And HFpEF, this HFpEF phenotype, many patients are labeled as having hypertensive heart disease. Although it's often, when you see them in the clinic, they often don't really have very high blood pressure. And it seems that people are just kind of trying to find the easiest label to sort of satisfy their need to explain the patient's disease. But I think my feeling is that we may have over-egged this relationship of hypertension and HFpEF, and there may be other factors in play. And actually, I mean, interestingly, the blood pressure by Mendelian randomization, the effects seem to be larger for the reduced ejection fraction phenotypes rather than the preserved ejection fraction, which are more typically the phenotype associated with kind of end-stage hypertension. So I think we're really rethinking this population. Actually, there's a study which I'm involved with called UKHFpEF, where it's a prospective study. We're enrolling these patients and going to analyze them in all possible ways, including genetically. And that actually sits alongside, there's a US program called HeartShare, which is essentially a parallel or a very similar effort. And I think we'll learn a lot from those studies. And I think we have a lot to learn. So this is just to summarize. I think we've, it's the last slide on this. If you look here, this kind of is all there to be found in the observational epi. And this was data from, I think, Geisinger. I think it's actually the wrong reference here. But looking at all patients who had an echocardiogram in the population and just relating the ejection fraction with mortality. And so this chart is showing the hazard ratio for all-cause mortality by ejection fraction, stratified by age. And what's really striking to see is that supranormal ejection fraction here has a similar kind of mortality outlook as people who have severe left ventricular dysfunction, it's severe heart failure. And this supernormal group just hasn't really been investigated at all. So we're very interested in looking at that and actually, studying that group genetically. I think I'll just skip through this. I think we're looking at other ways of trying to sort of tease out this. So contractility is an easy one because you can measure it with ejection fraction, but we think there are lots of other sort of latent etiologies or hidden risk factors that we don't have a biomarker for. So we're using different approaches to try and draw them out. And this was an initial foray with Spiros that we did together, where we actually found that if you take all the EHR codes in UK Biobank and then use, in this case, this non-negative matrix factorization approach, you can actually sort of rediscover the groups or the latents that relate to these contractility phenotypes. So so we're quite excited about applying this type of methodology to the EHR genomic data sets, because the biomarkers, whilst they exist, are not widely measured. So I think we'll be able to go further with this. I think just the last sort of bit is about, using, how do we treat these patients? What's the point? I think it's useful to understand the causes because it affects whether you revascularize the patients in the clinic, but it's also, useful to have some drugs. I spent a year actually on secondment of GSK in the heart failure unit, and my task was trying to provide an appraisal of whether BNP1 inhibition would be a good drug for heart failure. And I remember one of the talks around fibrosis and antifibrotics. I remember Colin Dollery sort of raising a question about treating heart failure patients with antifibrotics, about how do you know you're not going to cause an Achilles tendon rupture, and how's it going to work? And really, the animal experiments just don't provide any ability to make a judgment. So I think most of the time it has been a sort of gambling exercise when you're exploring new biology. And it's striking that all the drugs in heart failure are actually repurposed hypertension or diabetes drugs. So there's never been a drug apart from that myosin activator that was actually developed specifically for heart failure. So as I'm sure we all know, that genetic evidence has retrospectively seems to increase the odds of drug development success. I think we've got some work to do to understand what classes of genetic evidence in a more granular way are supportive, and to what extent, now that different types of study designs are proliferating to address this question. But I think, ultimately genetic evidence can help us to kind of count the cards, or at least, stack the odds a little bit in favor of success, whilst not being definitive. So we did a study here using O-link proteomics, where we sort of triangulated evidence from observational associations of circulating O-link proteins with incident heart failure by aggregating data for some large consortia, and then taking that set of proteins as a candidate set and appraising the evidence of the causal effects using Mendelian randomization. And this is a summary of our results. So there are 90 proteins on the O-link CVD1 panel, of which 40 had an observational association. 40 of the I think it was 44 had an observational association, but only 40 of those we had instruments for, and those are presented here in this sort of circular plot. The panel CVD1, as the name suggests, was selected, I think, by Lars Wallentin for proteins of interest in cardiovascular disease. So perhaps it's unsurprising that they were associated with risk, positively associated with risk. But it's interesting that, and then so the inner bit here is the observational association, and the outer ring is the Mendelian randomization analysis. And we performed a kind of multiverse analysis where we sort of, not knowing how to sort of what parameters to select, we just performed Mendelian randomization estimates with all possible parameters and combinations of models. And then we plotted here in this kind of violin density plot the distribution of the effect estimates under all those different models. And then green here is the sort of conventional independent instruments, and then blue is an estimate which derives from modeling the LD within the MR model. And through this, we've found some interesting things. I mean, NT-proBNP, which defines heart failure as a diagnosis, we weren't able to identify a causal effect, despite having a decent proportion of the variance explained by the model, by the PQTL instrument. And it's interesting that NT-proBNP is really a consequence and one of the things that comes downstream of the heart failure diagnosis. Another thing is this adrenomedullin, which is perhaps most interesting of all, where you've got this discordant direction of effect between the observational effect and the causal estimate. And I was initially thinking, this didn't make sense to me, and I was concerned, and actually presented it at a meeting where someone was from a drug company called Slingertech, who are developing this drug, which is actually a monoclonal antibody that increases it basically prolongs the half-life of adrenomedullin within the circulation, thereby sort of increasing the amount. And it's actually currently in a phase sort of 1b/2 trial for acute heart failure. And it's thought that adrenomedullin is actually a well-known biomarker for heart failure, may actually be activated by fluid congestion and have effects to try and maintain epithelial integrity. So that was, so I think it'd be interesting to see what the trial shows. Done a bit, I haven't really got much on heart failure progression, but we're still working on this, but we've managed to pull together data from lots of population studies and clinical trials, about 30,000 patients with heart failure. And this time, since much of the biology that we target with therapy is actually downstream of, within the disease process, we wondered if we could, identify and apply the kind of causal inference for both risk factors and drug targets using MR. And so we're working through this, but I think we probably need some help to navigate the complex issues. So I think that's really all I had to say. I think the future is really trying to decompose the phenotype even further, define the complex architecture of cardiomyopathies and begin to break down that divide between common and rare forms of heart failure. And I think there's a great opportunity with proteomics that we're definitely pursuing. And these are some of the key people, and I think I'll just highlight particularly Albert Henry, my sort of stellar PhD student, who's behind a lot of what I've presented. Thank you.
Thanks very much. Questions? I'll start with one, which is when the heart failure with preserved ejection fraction, which a million vet study I spent on, that's the big thing that we're looking at the moment. Is it a continuum there? I mean, do you really actually have these sort of two conditions? Because it seems to be defined based on just some sort of numerical value of ejection fraction, or is it essentially a sort of continuous phenotype across?
I mean, I think the palette model of complex traits is in a way the way to think about it, that there's sort of loading of different factors in an individual. And one of those factors is contractility, but there are other factors as well. And so I think there is I think there's been maybe your question is about, there has been a lot of conjecture about whether HFpEF is a phenotype which is on the way towards a reduced ejection fraction phenotype, and that that it's effectively we're just capturing people at a different point in their disease progression. But I think that's pretty well been proven not to be the case, and these seem to be divergent responses to similar groups of risk factors. So yeah, that's I think, yeah, we don't know much, but that's my take so far.
Thanks for a brilliant collection of work. Just at the beginning, you talked about one of the cyclopenic kinase hits you've got as an interesting target, 1A. I mean, we've seen others appear for loads of different health outcomes. I mean, 2A and 2B came up with diabetes and all sorts of other stuff from GWAS years ago. I mean, are those fundamental pathways useful as targets?
Probably not. I mean, it's quite. it is quite striking that CDKN1A has, if you look at a kind of PheWAS of it, it's very heavily skewed towards cardiac muscle phenotypes. I mean, it's a strong locus for QRS duration. So yeah, you'd think sort of intervening on something so fundamental would do horrible things, but it doesn't. And I do wonder whether it's, you know, there's a cancer, it's a sort of a cancer protective mechanism. You've got this balance between, you know, risk of heart failure and degenerative disease versus protection against cancer. But I think so. I'm not sure it's a great target for therapy, but I think it gives us insights into mechanisms which might somehow lead us there. But yeah.
There's a question in the chat. I can see.
Oh, yeah. Likewise, technology to understand what to do there.
Will there be much opportunity to increase sample size in heart failure GWAS via record linkage and big biobanks? Yeah, I think that's huge. I mean, we're trying to team up with MVP. I think that, you know, and merge the data there. And so I think there's a sort of a growing opportunity to do this. And certainly we're sort of eyeing up whether we can do something in our future health when it becomes a reality. I think, will it add value? I think just adding numbers to it is probably not going to yield. I feel like we've kind of, my feeling is we've got this HFpEF phenotype which we need to phenotypically disaggregate and understand better. And then the heart failure, I think what we need to do is focus on dilated cardiomyopathy and non-ischemic heart failure phenotypes, and that's where we'll make progress. But I think that, yeah, I think we've got a long way to go.
Brilliant.
Can you talk a bit more about this word for cycle and progression? How do you plan, for example, to define progression of heart failure?
Well, so this is, I should say, this is a project which is mainly led by Marie-Pierre Dubé. I mean, we've done it jointly between UCL and her team. So we have defined progression by using a time to event. So we use a Cox model, and we use these outcomes which model the outcomes of heart failure trials. So that's our phenotype. That's how we define progression. I mean, the problem with it is it's truncated in the sense that we have, you know, some cases who are prevalent cases, and we haven't yet begun to explore trying to adjust for that unknown time of onset for some of the cases. But I think there are some ways that we might approach that, but we're really at the beginning of exploring these data. I must say, I find it, you know, I'm not sure how far we'll get with it. I think it's methodologically so challenging, but yeah, certainly we're doing it.
And yeah.
What's the index of event bias adjustment that you used in that?
So this, I think we use Frank Dudbridge's tool, and I think there is a tool also from Bristol, isn't there?
Yeah,
Which
there's an update to Frank Dudbridge's tool, and
Right.
there's also the slope onto method.
Oh yes.
Here. And we're finding with a number of projects it's worth using there's different limitations with each of those methods, and actually sort of using multiple methods and checking that there's like consistency in results has been quite important. So yeah.
Would it be, yeah, it'd be great to connect about that, because I think we've got the data sets now, and so really
Right, yeah. So understanding balance.
Yeah, I've got a rush off to
Oh, yeah,
but
okay.
yeah, we should try and have a
Yeah.
chat about that.
Frank's involved in slope onto two, so Frank gets 3 references. If you try all
Yeah,
three,
yeah.
you try 2 methods out. So,
Can I just ask, how many of these HFpEF patients do you think really have cardiac dysfunction, or is that slightly controversial?
No, I don't think it is no, I think probably some of them don't, and there are probably other I think I sort of alluded to it. There are probably other sources of fluid congestion that are not renal and are not heart failure. That's my hunch, and that there's certainly, you know, there's a variance in that fluid retention that's not explained by the phenotype we observe. The other thing which I think is quite interesting here, which probably relates to misclassification of the outcome, is that we see that right ventricular diastolic volume seems to, you know, there seems to be, you know, the causal effect of that, and I think that's probably just patients with right heart failure. So that whenever we talk about heart failure, people are actually talking about the left ventricle, although it's never really explicitly characterized as that, but we're not really talking about core pulmonale in patients who have failing right heart because of lung disease. But I think there's a lot of those patients in our GWAS sample probably. So I think that, yeah, so I think it's, yeah, it's I think it's messy phenotype, and I think there's a lot of misclassification. On the other hand, there are definitely patients who have very clearly stiff hearts and hypercontractile function, I think, of a primary HFpEF.
I'm surprised Nick's not used the opportunity to advertise Alzheimer's childhood phenotypes, but something like heart failure, when you hypertension early on might trigger something which in the end leads to lower blood pressure, so which is why the MRI is expect to be a much stronger sort of causal effect on blood pressure. So with increasing size GWAS, there's a possibility of like using the genetic score for the outcome, and then looking what that relates to in
at different ages.
Kids, but it relates to kids who haven't got any disease at all yet, because the same sort of reversal you can see in principle.
I think it'd be super to do that, especially for the DC. I mean, this dilated cardiomyopathy, it's reasonably heritable, and I'm sure it has an early effects.
Yeah, so because we've got with Alan, I know you work with, I think, we've got lots of these. There's lots of
not all of those
phenotypes early on.
So well in younger age. Not all of those phenotypes behave so well in younger ages.
No.
But when they start to become jumbled up a little bit with growth and development. So things you anticipate looking unhealthy sometimes go the wrong way.
Yeah.
But it would be, I mean, yeah, I was going to try and catch it in.
I mean, I think it's, yeah.
I was thinking he's losing his touch.
I mean, the other thing which I didn't talk about as well about this common variations, we have all these patients who have been labeled as having autosomal dominant cardiomyopathy. I mean, that's been the clinical paradigm. And it's all about, constantly saying that they've got variable expressivity and reduced penetrance. Well, maybe it's just a complex disease. Certainly some of them have extremes of polygenic risk and have other risk factors. And I think that that's another area where maybe the childhood, lifelong studies will help us to understand what truly is a causal factor, whether it's a rare or common variant.
Yeah.
Is that a new question?
Oh, I don't know, I just left it randomly on here. Oh, a new question, sorry.
I don't know if that's
Oh, yeah. No, that's the old one. Yeah.
Well, that was any last questions? I thought that was really great and really good introduction to that area. Raises questions. We might go into link it. It's always good to have more questions at the end.
Well, thanks very much for listening.
Thanks, Tom.